I am Dr. Ted Barnett, the president and founder of Rochester Lifestyle Medicine Institute, and I'm so excited to welcome you to the November edition of Lifestyle Medicine Grand Rounds, using advanced technology and lifestyle medicine in managing treatment of a patient with cardiovascular disease, co-hosted by Rochester Lifestyle Medicine Institute and the William J. Folletti Center for Lifestyle Medicine. And we'd love to have you partner with us. We run several American College of Lifestyle Medicine certified programs, and we would love you to work with us to change the medical paradigm and empower your patients. We have online referral forms at our website, rochesterlifestylemedicine.org. If you fill them out, we will contact your patient on your behalf. We have a number of certified programs, which I'll tell you about in a minute. The lifestyle, the 15-day whole food plant-based Jumpstart program, which we developed right here on our stage, is certified by the American College of Lifestyle Medicine. If you, as a provider, take the program, you will receive 10 free CMEs. And the same thing with our LIFT project, which is also certified by the American College of Lifestyle Medicine. And we have ongoing health coaching, both group and individual coaching sessions. We run the Jumpstart every month. We're in the middle of the November one right now. The December one will be starting in early December. And we have a number of programs that you can get CMEs for, so please check out our website to learn about those. Please respect the privacy of anything you might accidentally learn about these patients, although we do everything we can to anonymize them. Our case presenter tonight is Dr. Kim Scheuer. She's board certified in both family practice and lifestyle medicine. She started the online focus practice Docs, Lifestyle Medicine, and also practices with Love Life Telehealth. Dr. Scheuer is licensed to see patients in 25 states. She's also conversant in Spanish and American Sign Language, which she uses to bring her knowledge to multiple communities. Our guest panelist tonight is Dr. Heather Shenkman, who is board certified as an interventional cardiologist in Tarzana, California. She graduated from Albany Medical College, completing a 6-year combined BS and MD program with the Rensselaer Polytechnic Institute. She completed a residency in internal medicine at Henry Ford Hospital in Detroit, and then a cardiology fellowship right here in Rochester, New York, at the University of Rochester, which was followed by an interventional cardiology fellowship at Tufts in Boston, another alma mater of mine. That's where I went to medical school. Dr. Shenkman is author of the Vegan Heart Doctor's Guide to Reversing Heart Disease, Losing Weight, and Reclaiming Your Life. While skilled at performing invasive procedures to open blocked arteries of the heart, she is a strong advocate for a healthy lifestyle, including plant-based eating and regular exercise. Staying active is a passion, and she is a 2-time Ironman triathlon finisher. Dr. Robert Breakey is one of our regular panelists. He's board certified in family medicine and lifestyle medicine. He's been a family physician in Ann Arbor for almost 40 years and serves as the medical director for IHA's William J. Folletti Center for Lifestyle Medicine. He's chair of the IHA's governing board, and he's also on the board of directors of several important medical organizations, including Rochester Lifestyle Medicine Institute. Dr. Kerry Graff is board certified in both family and lifestyle medicine, and she's a graduate of the University of Pittsburgh. She's also our medical director right here at Rochester Lifestyle Medicine Institute. And again, she's our case coordinator tonight. And I am president of the board of directors of Rochester Lifestyle Medicine Institute, and I used to be on the board of directors of ACLM. And thank you for attending. In order to reach as many clinicians as possible, we'd love it if you could make a donation. We do provide our CMAs for free, so consider aiming your phone at that, and that QR code will also put a link in the chat. And now, without further ado, using advanced technology and lifestyle medicine in managing treatment of a patient with cardiovascular disease. And I'm going to turn this over to Dr. Scheuer. Dr. Scheuer, welcome.
Hi, thank you so much. Thanks for having me.
Sure. And Dr. Shenkman, welcome as our guest panelist. And Dr. Scheuer, would you like to start sharing, please?
So I'm going to be presenting, as you mentioned before, using advanced technology and lifestyle medicine in managing treatment of a patient with cardiovascular disease. So just a background, cardiovascular disease is the #1 killer in the United States for men and women. 80% of it is preventable with optimal lifestyle habits. And optimal lifestyle habits actually can help reverse some aspects of cardiovascular disease. The lifestyle choices that are associated with cardiovascular disease are unhealthy diet, physical inactivity, smoking, excess alcohol use, and there has been some studies on stress and loneliness also. There are also medical conditions associated with cardiovascular disease, including high blood pressure, high cholesterol, diabetes. These are all modifiable, the lifestyle choices and the medical conditions, and that's good because that can help. Non-modifiable risk factors are age, sex, being male, and family history. So I'm going to just go over some screening guidelines really quickly. Blood pressure, the American Heart Association suggests checking every 2 years above age 20. USPSTF suggests starting at about age 18. Cholesterol, the American Heart Association suggests checking every 4 to 6 years starting at age 20. There are lots of tests that we use a lot and people know about. One is for an EKG, another is something for carotid artery stenosis. And currently the USPSTF recommends against using those on a routine basis, but on case-by-case basis, that's reasonable. And the adults between 40 and 75 should undergo what's called a 10-year ASCVD risk estimation. This is being currently reviewed and updated by USPSTF, but you would talk to your doctor about those. So in this case presentation, I wanted to just introduce some of the things we're going to talk about. One is a coronary artery calcification score. USPSTF currently has that as an I rating, which is being reviewed, but that's insufficient evidence to suggest using that routinely. There's also a CT angiogram, which both the CAC and the CT, if you look at that first picture on the left, are CT imaging options. And the American College of Cardiology and the American Heart Association recommend CTA. So the angiogram for use in people who have stable or acute chest pain with no known coronary artery disease. There's also something called a CIMT, a carotid intimal medial thickening test, which is controversial and not widely accepted. And the reason, and that checks an ultrasound of your carotid arteries to see if there's plaque in the artery, not only in the artery itself, but also in the artery wall, which is which can be more dangerous. It also shows vasodilation and tells the health of an artery, but it is very dependent on who is running the test. And so that's why it hasn't been as standardized. But these are things that we talk about with our patients sometimes. And I did talk about it with my patient. I'm going to present a GI who is a 73-year-old male, first seen in January of 2024 with concerns about cardiovascular risks. He was concerned because he has high cholesterol. He also had a history of prostate cancer treatment, but that was successful. He's on no meds. He was on some supplements, including B12, C during COVID times, and continued D3 omega, vegan omega, and lutein zeaxanthin. No allergies, but he had a very, very strong family history. All of the men on his father's side died young of cardiovascular disease, and he was concerned about this. His father also had severe heart attack and died. His mom's side had longevity. He lives with his wife and teenage children and wanted to set a good example for his children. He's also he doesn't smoke and he doesn't drink. He is an AA, and rare gummies, very rare. He exercised 4 days, 40 minutes each. His sleep was good. Overall, he didn't have any complaints for sleep. He slept 5 to 7 hours when working and 8 to 10 hours 1 day a week. He works a lot, but his stress was minimal, except for when he found out his cholesterol was so high, and that made his stress a 10 in terms of his health. Otherwise, he's has good family support, good community support, is involved with AA, is religious, and good religious support from his community. He says he's a whole food plant-based eater, but dines out often, and his words was exposed to too much salt, oil, and saturated fat. But on more discussion, he does eat a lot of processed foods at home, including Amy's gluten-free options. So his risk factors are age, sex, his male sex, and his family history, and his current cholesterol. His vital signs were he had a BMI of 25.06, a blood pressure of 120/65, and his labs, you can see he'd had a total cholesterol over 200 for several years and an LDL over 100, even at one point over 100 throughout. And he did get a ApoB, which was high. And that is another risk factor for cardiovascular events. His Lp(a), which can be a risk factor, was ideal. It was 50, and that is genetic risk. So that was one good point. But his ASCVD score was for a 10-year risk for having cardiac or cerebrovascular event was 22.2%, which is considered high. So given that information, what would you do with him? Tell him to postpone conventional medicine, which includes statins, for 3 to 6 months while he does aggressive lifestyle changes. Offer advanced testing, the CIMT, the CAC, or the CT angio that we discussed, or other advanced lipid panel testing before considering treatment, but telling him to follow the pillars of lifestyle medicine while awaiting results, or tell him to follow all the pillars of lifestyle medicine while pursuing conventional medical therapy.
Oh, interesting. Bob, can you put up the poll? There it is. Okay, so if our audience could please, as quickly as possible, pick one of those and hit submit. All right. Well, I'm going to ask Dr. Shenkman to weigh in on this, if she could, please. What would you have chosen, and what do you feel about these other choices?
Okay, I honestly, with the information given, he's high risk, he's older, he's got elevated cholesterol. You plug his numbers into a risk calculator, he's going to come out at being having a greater than 20% risk of heart attack or stroke in the next 10 years. Much of that is driven by his age, in spite of whatever good lifestyle habits he has or will achieve. And I would tell him, based on that, that if you were to add a statin medication on top of all the good lifestyle medicine things, that you would get a roughly 30% reduction in risk of cardiovascular events in the next 10 years. To some people, that's worth it. A pill every day to reduce my risk by 30%, done. For others, it's the burden of having to take a pill every day. They just don't want to take more pills. The downside, certainly, of statin medications is that they can have side effects, and roughly 5 to 10% of people get muscle aches that are bothersome enough that they would discontinue the medication. And present that up front. But I think that's what I would do. I mean, I would choose number 3.
Okay. Dr. Breakey.
Yes, this is really one of those shared decision-making approaches, so that it depends as you're talking with him. And in lifestyle medicine, we really work with people to see where they're at. And as Dr. Shenkman mentioned, it really kind of depends on his willingness, desire, aversion to medications, and really how willing he is also to fine-tune his already good lifestyle. But when it's this far along, when he's over 20% risk, he's either got to get to great, like a true Esselstyn sort of jumpstart model, or really go ahead with the statin. And in this case, probably both. So I also chose number 3, just given the info we have. I know at Vegan Summerfest this year, Dr. Greger was pretty direct, and people with high risk, you've got to kind of do whatever it takes to get them to that goal, recognizing that if he had started earlier, Dr. Scheuer, you mentioned that we have like 80% of these can be prevented. Really, 100% can be prevented if we started from before birth. If you look at areas of the world where people don't eat the foods that create this challenge and don't have the stresses and get daily exercise, that study out of Rwanda where 1,500 autopsies, only one had one non-fatal heart attack. And, but given that he's got this backlog of challenge from being an American all these years, he now has some makeup to do. And that's optimizing his new lifestyle while also, where necessary, taking advantage of medications.
Dr. Breakey, does this fit into your concept of SAD years?
Yes, that kind of backlog. Kerry and I have been working on this concept of just like you have pack years for smoking, how many years at what percent of the standard American diet? So if he, I don't know, we didn't get exactly how long he's been out, but just let's say, for example, he's 73. If 10 years ago he started seeing the light and he became vegetarian and he was kind of 50-50, still processed foods, spent some eggs and dairy, then it'd be 63 years of 100% SAD years, and 10 years of 50% gives him 73 SAD years. That's a heavy, just like if someone had a 70-pack year smoking history, that's a heavy burden that has to be kind of undone. In contrast, if like me and Dr. Barnett, he 20 to 40 years ago had discovered a whole food plant-based lifestyle, he might not be where he is here today and could have then therefore done it with just lifestyle as opposed to having to augment it with medicines. So yeah, thank you, Ted.
Sure, thanks for that. Yeah, Dr. Graff, what do you think?
I didn't like my options for my questions because what I really wanted to do was have a conversation with him with, realistically, how much can he do in terms of changing his diet from where it is to get to an Esselstyn style diet? And if he says, realistically, I'm not going to be able to do that, well, then we're going to move right into starting the statin. But if he thinks he could do a good job on that, I'd love to know how much could come down just with the diet. Because if you do the diet and the statin at the same time and you get this nice plummet, which you're expecting, then he's going to think it's all the statin and it's not the diet, and he doesn't really have to change his diet, and he's going to kind of continue to do the things that are not the best for his health. So I would think about doing like a 2-week whole food plant-based jumpstart type of program where you're doing it all in as close to perfect as you can, rechecking that cholesterol, throwing that back into the risk calculator, and then kind of see, are you where you want to be, or are you going to really need to be on a statin as well?
Yeah, interesting. Thank you for that. Dr. Scheuer.
Well, it's interesting. I mean, I wonder even if doing that, if because of his age, it would still be so high. But okay, we're going to go to the next one. So he declined medication. We talked about some of the other options that I mentioned previously. I suggested he start a very strict whole food plant-based SOS-free Esselstyn diet and be much more compliant. Emphasized all of the lifestyle pillars. Even though he's pretty good, he could improve on some. Talked about sleeping more regularly all through the week. And we talked about adding some Brazil nuts for selenium, amla, which is dried Indian gooseberry, soy, psyllium husk, and bergamot. All have had some studies that say that they can bring down some cholesterol. Not all of them strong, but anything that would help him. We discussed some videos by Dr. Clapper on cholesterol, and Mike the Vegan has a good video that talks about scientific evidence and techniques to lower cholesterol without medications. He's very scientific oriented, very much like Dr. Greger, but for the younger crowd. And we discussed the quality of life, whether, why he didn't want to be on statins and what his concerns were that way. And so that's how it started. He stopped eating prepared food and eating out. He actually stopped eating out. He added all the things we discussed. He really wanted to do testing. He wanted to see empirical evidence of, but he couldn't find a coronary artery calcification score or a place to do a CAC or a CIMT locally. He continued to optimize all of his lifestyle habits. And by June, he was down to a BMI of 23.18. He'd lost significant weight. His blood pressure now was regularly under 120/80, whereas before it was borderline. In March, he had an ApoB that was down from the 120 he had originally to 95, still not the best range, but certainly going the right direction. His cholesterol had come down significantly. Oops. I tried to change the CDL to HDL, and then it was actually something else, but that's his HDL was low, but his LDL had come down. And his non-HDL had come down, and on this scale was in a normal range. On his own, because he couldn't get the CAC and the CIMT, he was trying to find other ways to prove to himself whether he had carotid, any cholesterol and stenosis. So he had gotten testing for an ABI, aortic ultrasound, carotid ultrasound, abdominal aortic ultrasound, and all was normal except for he did show some stenosis in the bilateral common and external iliac arteries and popliteal arteries, which is concerning because if there's cholesterol anywhere or blockage anywhere, it's gonna be everywhere, in my mind. His risk stratification came down to 19.8 from the 20 over 22, I think it was. And that was now intermediate, but still not low. And he was having a hard time staying on this pristine diet. He on his own had set up a CT angiogram and was getting something called Cleerly, which I had not heard of in June. And so in later June after our visit. So that was his plans. He got the CT angiogram, and the CT angiogram, remember, shows it shows a bunch of things, but it showed as part of it showed a coronary artery calcification score of 218. So calcification is left anterior descending, his left circumflex, and his posterior descending. His left anterior descending showed severe stenosis due to predominantly non-calcified plaque. And we worry about non-calcified plaque more than calcified plaque. And his left circumflex showed severe stenosis in the mid-segment, secondary to non-calcified plaque, the more unstable plaque. And this was in June.
I just want to ask Dr. Shenkman, if you could just sort of talk about the difference between calcified and non-calcified plaque. And
Great.
what you,
So calcified plaque tends to be stable plaque, whereas non-calcified plaque includes the softer, more vulnerable plaques that will break off and cause heart attacks and strokes. And that's in fact the most common mechanism that we see of heart attack. We don't see narrowings that go 70, 80, 90, 100%. That's not how heart attacks happen. Heart attacks happen when a plaque ruptures, travels downstream to typically a narrowing that's like 30 to 50%, and then boom, suddenly closes it off and obstructs blood flow to that portion of the heart. So there is a significant difference. And also, fun fact, if you put somebody on a statin, their coronary calcium score and their quantity of calcified plaque goes up, because the mechanism of the statin is to stabilize plaque, and it stabilizes plaque by calcifying that plaque. So once you've got somebody on a statin medicine, you do not repeat coronary calcium scores because it's going to be meaningless.
interesting.
I've
Thank you.
also heard that if you go on a plant-based diet, it can go up because you're stabilizing.
Yeah,
That's
interesting.
true.
Yeah. All right, let's hear the poll, please, before we're there.
Okay, so then would you send him to the ER? Would you send him to a cardiologist? Would you start him on a statin and aspirin immediately? Would you do number 2 and number 3? Would you wait for the Cleerly results before doing any of the above?
Let's see. Dr. Shenkman, what do you think? Looks like the most people said they would do number 2 and number 3.
I agree with that wholeheartedly. First of all, a couple of things here. So first of all, he underwent imaging of his vasculature, and he's got iliac plaque. So by definition, he has vascular disease. That is somebody who should be on an aspirin statin, on that information alone. But also, you've got a high coronary calcium score. You know, even if you didn't know something about the coronary anatomy, you would know, CT coronary calcium score greater than 100. There is data to show that aspirin and statin therapy will lower cardiovascular risk. So I think, independent of knowing the Cleerly information, this patient definitely would benefit from an aspirin and statin.
Excellent. Thank you. All right. Dr. Breakey, your thoughts on that?
I would agree. He's at a stage now where it's not only that 19% still on the risk factor scores, but that LAD is the proverbial widowmaker, and with a significant lesion there, predominantly soft plaque, he's at high risk. And I guess what I tell people is a statin and aspirin isn't necessarily forever. We need to kind of get you stabilized, work down some of the backlog, focus on all pillars of lifestyle medicine. And oftentimes that helps them feel a little better, like, okay, because I've heard that once you're on it, you're always. And I said, well, that's usually the case because most people don't accompany that with lifestyle measures that may help to do that. But I also help people to understand that a statin not only helps lower cholesterol, but is an anti-inflammatory. And that initial phase of atherosclerotic plaque development is inflammation. And Kim, I'm trying to remember if you mentioned his HSCRP, IL-6, or CRP levels to kind of see where his levels of inflammation are. But regardless, he's obviously had a pro-inflammatory past resulting in arterial injury, and the resultant backlog that he's developed there within his arteries needs a little more critical approach to that now. Medications are not to be feared when needed. We try not to use them, but if you need them, you need them.
Thank you for that. Dr. Graff.
I would agree. I picked 4. I would not send him to a cardiologist because it seems like cardiologists, no offense to our cardiologists on the panel, but they kind of just send everybody for a cath and stent them, whether they're having stable symptoms or not. So I'd be a little bit more reluctant to do that unless it was something that I really didn't feel like I had a good basis for knowing what I was doing with this person.
Dr. Shenkman, would you
Can
like to
I
respond
pipe in
to that?
here?
Yeah.
I don't know that every cardiologist would send this gentleman for a cardiac catheterization. I think there's some that would, but I think that those of us who know the data, who would take a bigger look at the bigger picture of who this person is somebody who's asymptomatic, who's got some a fairly abnormal CT coronary angiogram, who's asymptomatic. I think I would perhaps put the patient on my treadmill and just do a basic treadmill stress test, see how much exercise they can do, see if there are any EKG changes. And if I saw something abnormal there, even if they reported to me initially that they were asymptomatic, that might make me more likely to send that patient for cardiac catheterization. But I wouldn't just say, let's go cath you, and I'd also reinforce whatever the primary care doctor's lifestyle recommendations are. Because sometimes hearing it from 2 different doctors, a specialist and a primary care doctor, helps to drive that home.
Great. Well, thank you for that. So I know Dr. Scheuer is going to explain what Cleerly is in a minute here. I'm going to actually jump in real quickly as an interventional radiologist. I just want to make it real simple. People should understand that the patient had, Dr. Scheuer, you can correct me if I'm wrong, but the patient had the coronary angiogram, and that we saw those results. Cleerly is just taking those those images and those data and processing it with artificial intelligence, correct?
Yes.
They're just using the okay. Proceed, please.
So this patient wanted to wait for the Cleerly results. He did schedule with a cardiologist, as I requested, but he didn't want any treatment until seen by the cardiologist, even though I did suggest the statin and aspirin. Interestingly enough, he had been called by the hospital to come for an emergency cath, but since he was asymptomatic, he refused, and I did support him on that since he was asymptomatic. Had he been symptomatic, that would have changed things a little bit. Let's talk about Cleerly. What is Cleerly? So Cleerly is AI-driven analysis of the angiogram. It's detailed vessel by vessel evaluation of stenosis and atherosclerosis. It can differentiate. They say it can differentiate higher risk plaques from more stable plaques. At the time he got this, it wasn't covered by Medicare, but now it is. And we'll go for more. This is some of the imaging that Cleerly does. You can see in the middle on the top, it shows the heart and the vessels as they come around the heart, but you can actually take those vessels, you can see them like that, or you can straighten them out. And it shows both plaque and stenosis. The yellow is the plaque, the stenosis, you can see the narrowing of the vessel. They also, so what they do is they stage and they predict long-term cardiovascular outcomes in patients at risk for atherosclerosis. And they've done studies, and through 10-year follow-up, they show that they say that they're more prognostic value for MACE, which is major adverse cardiovascular events. And they show additional discriminatory value over clinical risk factors from just the manual guideline recommended catheterization techniques. They stage from 0, 1, 2, and 3, and they are pretty aggressive in suggesting what the treatment should be based on the staging. This is his. What they showed was the total amount of cholesterol buildup, the plaque volume, basically. He had some in his right coronary, his left main, left anterior descending, his circumflex in the total of 332.9. They showed the percent that was calcified versus non-calcified, the volume. They staged him at 2, and I hope this goes back. Yeah, so they would suggest the high intensity statin, ezetimibe, aspirin, and also a preventative blood thinner, and if diabetic, a GLP-1 receptor agonist. So that's what they were suggesting, and then repeating this in 2 years to see how he's doing. But you can see that they talked about his circumflex being 55% stenosed, and more moderate, and the LAD was only mild, 41%. And these were, you can see how his vessels looked when you straighten them out. They show the total plaque volume in each of the vessels. They show the non-calcified, so the low density non-calcified plaque volume, which is the highest risk, the non-calcified plaque volume, which is moderate risk, and with instability, and then the calcified. They also show something called a remodeling index. And his was greater than 1 in several vessels. So this is complicated, and really, just taking what you saw on those straight lines and putting them in written form. But basically, the atherosclerosis was stage 2. That's the plaque density. And the stenosis, they felt was mild in the LAD, moderate in the circumflex in certain areas, and minimal in many of his other ones. But he had 0% of the soft non-calcified plaque, but he had significant non-calcified plaque, and that's why they put him in stage 2. And the remodeling index that I talked about of being greater than 1, per them, indicates positive remodeling, which needs for careful monitoring and aggressive management to prevent plaque progression, because it means there's more likely for rupture, and it indicates vulnerable plaques. So my concern was there was a big discrepancy, I thought, between Cleerly and the angiogram. And so I had them re-look at their report. It didn't matter. I still would have suggested the exact same thing, but I was curious as to why there was such a discrepancy in the left anterior descending, and why it was read so differently. They stood by their original reading on the left anterior descending, and felt that it was at most 50% blocked, so moderate most, but they continued to label it mild. They did look at the circumflex again, and they felt that was more stenosed than originally thought. They said normally there's less than there's a 1% discrepancy with CTA and Cleerly, but they had their best radiologists look at this, and they stand by their findings. Again, wouldn't have changed what I would have done with him, but I did think that was interesting. So here's what happened. It wasn't his risk factors. It wasn't his scores. It wasn't his number, his the rest of his testing that he'd done. And it wasn't the CT angiogram that made him reconsider medications, or it wasn't me. It was the results of the Cleerly, which I thought was very interesting. He had to visually see that for him to decide that he needed to change. So he was seen and followed by cardiology. He was started on actually a lower dose Crestor, lower dose statin than the high dose recommended by Cleerly. He started on a baby aspirin daily. And while on the statins, he dropped his cholesterol even further into much more of a comfortable range. Although I think that, and I'd like to ask the cardiologist's viewpoint, but I would like to see his LDL less than 50, actually. He's continuing a whole food plant-based diet, but not as pristine as while he was on meds. And that's concerning to me because being on maximizing the lifestyle, maximizing the meds, the diet not only prevents risk from the cardiovascular disease, but from cancer and lots of other issues too. So he was maximizing all of that except for the whole food plant-based diet. He was a little bit more lax at this point. And we Cleerly, and his cardiologist had suggested rechecking in 18 months to 2 years. You don't want to do too much too often because you don't want to have too much exposure to radiation, but that's what they said.
Well, can you go back to that slide, please?
Yeah, absolutely.
I just asked our cardiologist, Dr. Shenkman, what are your thoughts at this point?
I would agree. It would be beneficial to get his LDL lower. Depending on which guidelines you look at, LDL in somebody who has known cardiovascular disease should be less than 70, definitely, but preferably closer to 50. And there definitely is a relationship. The lower you get your LDL cholesterol, the better. So if he's tolerating Crestor 10 milligrams, which is really a moderate intensity statin, he really should go up to a higher intensity statin, either 20 or 40 milligrams of Crestor. But also, I question this recommendation of rechecking a Cleerly, of exposing him to this large quantity of radiation, because it's a significant amount of radiation, and administering contrast and everything that goes with it. What's honestly gonna change if he is asymptomatic, quite honestly?
Right.
It's a good point.
Yeah. I had a question too, Dr. Scheuer. It sounded like he made his decision based on seeing the Cleerly images.
Correct.
Did he not see his images from the original CT angiogram?
Honestly,
I wonder if
I
that
don't know if he saw the report from the CT angiogram, but I don't know that he saw the images. That's a
Because
good
I wonder if that would have been enough if he had just seen those images, whether he would have said, "Oh, that's what it looks like. Oh my God, I should, I need to be on something."
He called me and he said he was called in, and we had an appointment that day because I was very concerned about it. I agreed with him that I didn't think he needed to go in right away for a cath, but I was really strong about he needed to see the cardiologist, which he'd already made an appointment, which was great. But I don't know that he saw those images. It was the Cleerly, we went through it, vessel by vessel. And that's when he finally decided. That was before he saw the cardiologist. But even but he didn't want to start the meds. He was like, yeah, I think I need to be on meds, but I'm seeing the cardiologist in a couple of days, so I'm going to wait. So.
Right. Any other comments on this page from before we move on, Dr. Breakey?
Yes, several great teaching points here, Dr. Scheuer. I think your excellent case. And I agree, following with cardiology is important for him. He's high risk. And I also agree in the chat there that, as Dr. Shenkman mentioned, there are cardiologists, most of whom are getting much more aware of and supportive of lifestyle medicine. And in our area, Dr. Frank Smith, Dr. Paul Nona, I know which ones to refer to who are not going to push too much too fast, and recognize that this is not just a person with the standard American risk and lifestyle anymore. Because he's following a better lifestyle, his risk curve shifts. and you don't need to be as aggressive, largely because of that inflammation marker. And statins, even at lower doses, even though it's a dose-response relationship for cholesterol lowering, even the lower doses are more anti-inflammatory. So I would agree with, rather than, as they mentioned, start with 40 right away, try this 10. You've seen that you've got a good result, but not as good as we'd like. I agree, 75 still too high. But that point number 4 is critical. And this is a common thing. People on diet sodas tend to eat more high-calorie things because they're they're doing good over there. So because the medicine has it handled, he's not eating as healthy. And I agree with you, Dr. Scheuer. This can lead to other problems, including higher risk for Alzheimer's, recurrence of his prostate cancer, and other vascular disease as a result. So we do need to have that conversation with him again and say, hey, you're still not at goal. We can bump up your medicine. I know you don't want to do that, but we either need to do that or get you more pristine again, and see what he's willing to do. You can't push people beyond what they're able and willing, while also emphasizing the other aspects. We frequently talk diet here as the major, because it is, but also stress management, sleep, exercise, and social connectedness are also critical. And I agree, you don't need to recheck the Cleerly. It's the equivalent of 800 chest x-rays and radiation for a CT angiogram. Even a CT coronary a calcium screen is 150 chest x-rays. Now, in fairness, a chest x-ray is a low level of radiation, and even a CT angiogram is only about 4 times the equivalent of what we get from background radiation in a year. But to have in 5 minutes what you'd usually get 4 times what you get in a year for usual background radiation, which is what most humans have had since we evolved. It is a lot of radiation, and since it's not going to change or do anything differently, it's just going to sort of be a good marketing plan for the people who do Cleerly.
Great, thanks for that. Dr. Graff.
Just putting in a reminder that we don't want to repeat a CT calcium score here, because it's going to look worse, not better, and then even though the patient's risk will be lower. So just don't want to use that to follow, and I've got hiccups, so pardon me for that.
Sure, thanks for that. And I'll just mention that so Rochester Lifestyle Medicine Institute does have this 15-day whole food plant-based jumpstart that does teach basically the Esselstyn diet, and we've had very good success with that. And you can call that a commercial plug, but we are a nonprofit and I'm a volunteer. So anyway, we highly recommend that program. All right, Dr. Scheuer, what's next?
I have a quick question on this. Sure. If for some reason he gets his LDL down more, and if he stays with a pristine diet for years, Dr. Breakey, you mentioned about possibly getting him off of some of this. Any idea how and when?
Again, I try to help people hold out hope. One of the people in the chat said some cardiologists are concerned. Cholesterol actually has some properties like crystal, and they've done at the International Conference on Nutrition and Medicine about 5 years ago. They showed some scanning electron micrographs of cholesterol crystals poking through, and there's some evidence that this kind of continued adding to those crystals, just like in 4th grade when you put the saturated sugar solution overnight, is what may help lead to some of the rupture. By decreasing the inflammation, by getting their hs-CRP low, by helping to seal over, to calcify, as we said, calcify those plaques that are non-stable, you may be able to get things stable enough to either lower his dose, or sometimes when people are especially concerned about statins, and again, they do increase risk of muscle aches, of diabetes, that there are downsides with respect to cost, and maybe things we don't even know. I mean, it was a couple decades before we even recognized that statins increase the risk of diabetes. Not to overplay that, because, huge decreased risk in coronary artery events is better than a tiny risk and increase in diabetes. But anytime you put that finger in the dike and just say, we got this handled, you've got that offset effect between people not doing what they need to do themselves as well, as number 4 mentions here. So sometimes what I'll do on people who are especially keen on getting off their meds is optimize their lifestyle and then maybe switch them over to Zetia, and see if I can still hold the cholesterol in an adequate range. I don't know. I'd be interested in Dr. Shenkman's thoughts on this too.
Some interesting points you bring up. I'm going to be honest, I wouldn't feel comfortable taking a patient off of a aspirin and statin. Certainly not a patient like this. I'm not sure what endpoint you would specifically look at, but the patient had, in spite of the recent good habits and healthy lifestyle, the patient has coronary disease. And I don't know that there's any role of short-term therapy. If somebody was having myalgias or muscle aches on a statin, I would perhaps consider switching them to ezetimibe or putting them on Repatha, which is an injectable cholesterol medication. But I think that if they tolerate an aspirin and a high-intensity statin and their lipids are at goal, nice and low, and they feel well and they're not having muscle aches, I think I'd encourage them to stay on the therapy long-term.
Thank you.
Point. Yeah. There's a question in the chat, the last one that went in. Somebody asks, how low of a total cholesterol and LDL is too low? Dr. Shenkman.
That's a great question. I don't think there is such thing as too low, quite honestly. I mean, there have been studies looking at people who are born with PCSK9 genetic abnormalities who, as a consequence, have very, very low baseline LDL cholesterols of like 10 or 20. And they get through their lives. They're not at increased risk of problems. In fact, their risk of cardiovascular disease, for the most part, is very, very low. So, I mean, if I've got somebody who's on a high intensity statin, like they're on rosuvastatin 40 milligrams or atorvastatin 80, and we see that their LDL cholesterol gets down to like 20 or 20, like I might cut the dose in half, but I certainly don't panic and say, oh my goodness, this is going to cause you harm, because it's probably not going to cause any harm.
Right. Thanks. Yeah. All right.
Okay. So my last one is just a general, if we had time. I found, what help patients, and in this case, Cleerly helped this patient decide to be on what I would have considered appropriate treatment. CGMs, continuous glucose monitors, have helped me with some of my patients, recognize how their diet and lifestyle affects what they eat and what their sugars what goes on with their sugars. I've used apps like the Daily Dozen, but wondering what everybody else has used. And the big question for me is, how do I keep him on a healthy lifestyle once he's on medicines? Because I've had a lot of patients who are like, okay, I'm taking the medicine, now I can eat whatever I want, which is not, I think, healthy. And then last is just a big society change. But I didn't know if anybody had any suggestions, and I'm going to stop sharing, I think, at this point, if that's okay.
That's fine. So, yeah, that's great. Thank you. I got the questions up on my screen here. So, Dr. Shenkman, any other newer technologies that have particularly excited you?
I think Cleerly is particularly interesting. CT coronary angiography has definitely changed my pattern of what I do. I do a lot fewer diagnostic cardiac catheterizations, because being able to send somebody for a CT coronary angiogram, and even adding the Cleerly data, can really reduce the number of invasive procedures that we do.
Dr. Breakey, any thoughts on that question? Other newer technologies like CGMs or any apps?
Yes, I definitely recommend the Daily Dozen app and the 21 tweaks that goes with it. It helps give people a kind of easy to do, make the right thing, the easy thing to do for people. I do not recommend CGMs for people without diabetes or even with relatively well-controlled diabetes. It can be confusing for people, and they get hyper because blood sugar is supposed to go up when you eat. Eat a sweet potato, it goes up, and they confuse that with, oh, I'm not eating that anymore. That's normal. Or they find out that they put butter on their bread, it doesn't go up as much. So the butter must be good. Well, that slows digestive emptying time and is counterproductive to your real goal. So again, there's a place for people with obviously type 1 or challenging control diabetes. but don't recommend the CGMs. Your second point there, Kim, is really the key one. I call that the finger in the dike phenomena. People think that because, oh, I got this blood pressure med or this cholesterol med, I've got it handled, and they can eat what they want, but the water's still building up behind the dike. They put their finger in the dike and bam, it breaks loose, and suddenly they get a diagnosis of breast or prostate cancer or of gallstones or colon cancer, and they're saying, wow, I wish I should have looked at that canary in the coal mine. That high blood pressure is stiffened blood vessels from inflammation from chicken and cheese, and they cured it by forcing the vessel open with lisinopril, but they haven't got to the root cause of it, which continues to beat up. And then your last point, boy, how societally we get this going. I was so pleased at this year's ACLM meeting to see ACLM partnering with Blue Zones, because that really is the key. I mean, Dan Buettner has said it, and we've all experienced it. You teach people what to do, they nod, you feel like they've got it, and then they go out into this jungle where Madison Avenue and misinformation from studies that butter is back and well-intended relatives who read The Big Fat Lie are telling them that saturated fat's good for them and they're going to die of protein malnutrition. And their fourth grade teachers for basic for a food group, and their head comes back and they throw up their hands and go, this is all too confusing. I'm just going back to what I'm doing. So by having the environment right, the family, the community, the Blue Zone kind of mentality, that's what will help us ultimately, because we lifestyle medicine docs are paddling upstream if we think we can undo all that with just giving people information. So thank you for bringing that piece up, and let's make the United States a Blue Zone. Oh my gosh, who's this? Hi.
Hey.
This is my kindergarten daughter, Ava. She popped in to say hello.
You are so
Ava.
cool. Thanks for joining us.
Yeah, yeah. All right. Well, since you just did a shameless demonstration of your beautiful daughter, I'm going to put up a little shameless plug here really quickly. This is just for people. Thank you all for attending. We're going to officially dismiss in a couple of minutes here, but once again, we are a nonprofit. We depend heavily on our donors, and if you could feel so moved, we'd love it if you could make a donation to help us continue our work. And with that, Dr. Graff, how do we change society so that it's easier to be healthy and not have to rely on medications?
I think that we need to meet people where they are and gently lead them to kind of adding in more whole plants. I think that sometimes when we bonk them over the head with we need to be eating a whole food plant-based diet, there's so much instant rejection that happens with that. But finding things that they like to eat, they like oatmeal with blueberries or bananas, they like a minestrone soup, and just trying to kind of get them to eat more of those, double up on those, and keep increasing it over time. And that's something that most people don't push back so much of, and versus adopting an entire new diet overnight. And at some point, I think you get to a point where with a lot of folks anywhere where they're like, this is doable and I'm getting so much better. And the more they do, the better they get. So, but trying to get physicians in a position where we've got time to discuss that is, very difficult.
I think that's good advice. But I will just say that Dr. Graff and I are on the same team. She's our medical director, and she's the good cop and I'm the bad cop. I definitely try to get people to make changes suddenly, and I do often hit them over the head, and then they go running to her, which is fine. But because I do think there are those people out there who, once they find out how quickly they can get better on a really short program, they go, it's very motivating. And it's sometimes they'll, from our point of view, I mean, there are different kinds of programs. The kind of programs that we teach are very, short and to the point. And we tell people, look, you're a grown-up, you can do anything for 2 weeks. And when they get their labs drawn at the beginning of that and at the end of that, and they say, wow, my cholesterol really dropped 150 points in 2 weeks. And we go, well, that's what the labs show. And then they say, gee, I guess this really does work, as opposed to just making a few little changes here and there, where they might not feel better. Their labs are not going to change a lot, and that, they kind of drift off. So now, do people stick with it? Not necessarily. they might take a couple of tries. It's like smoking. And they might wander off the path, after a couple of months, but then they remember, gee, that worked for me before. I think I might try it again. So it looks like Dr. Scheuer wants to say something. She's got that look on her face. No? Or she's
Just gonna say that it looks like it's a different population. So the folks who show up to a 15-day jumpstart, they know what they're in for. They're
Right.
ready to go in all at once, which is great.
Mhm.
But if you're in the primary care world, those folks are in a whole smattering of different levels. Some aren't ready to make any changes at all. Some are ready to make some slight changes. So just kind of gauging kind of where people are and kind of just planting the seed, moving the needle along over time, and hopefully eventually you'll get somewhere.
Yeah, no, thanks for that. So we are going to wrap it up, but we will let people make some final statements here. But I just want to review how this works. For those of you who attended, you will be receiving an email in the next few hours that will contain the link to a survey. Once you fill out that survey, you will receive a PDF worth 1 CME in your email inbox. So thank you all. Dr. Shenkman, any final words for us? Our guest cardiologist?
No, I thought that was a really good case. Thank you for sharing.
Yeah, absolutely. And yeah, Dr. Scheuer, thank you so much for a really interesting case. And I know you worked hard at putting that together. And I have you have the hard job, the person doing the presenting. The rest of us, especially me, have the easy job. I guess to just, throw rocks. So anyway, Dr. Breakey, any final thoughts?
Yes, I think Kerry and Ted both have good points on how fast. And it's really the ICLM readiness to change model of kind of whether and how ready they are to kind of go all in or not. And you don't want to put the wrong person in the wrong category. I should say, though, that Dean Ornish kind of went through an evolution in this. In his early book, The Spectrum, it was all about, okay, start here, sort of, and go gradually one step at a time. In his most recent book, Undo It, he recognizes more towards Ted's approach to say, if you just make incremental change, you feel the deprivation of, having to miss out on those steaks and the baked Alaska, but you don't get as much change as you would hope for. So it doesn't really change because you're still eating chicken and cheese. So you haven't made any difference, and they don't stick with it. Whereas when you get that, I see the difference, I feel better, I'm going to stick with it. So I tend to lean more towards, trying to encourage people to try that, hey, do enough. And this is going to be interesting at our next lifestyle medicine grand rounds, the sort of therapeutic dose of lifestyle medicine. So often people get a subtherapeutic dose, just like if you gave them 1 milligram of Lipitor, you wouldn't be surprised if they didn't have and if you just do an American Heart Association diet and replace red meat with chicken, which is still 60% fat and high in saturated fat and pro-inflammatory, and egg whites, which also raise cholesterol and the high methionine. Anyway, we could go on, but the idea is you need a therapeutic dose enough to make a difference enough so that their numbers reflect it, so that they feel better, and most importantly, so that their outcomes reflect or improve, whether it's risk for heart disease, stroke, or other comorbidities.
Yeah, thanks for that. And thanks for mentioning our next month's Lifestyle Medicine Grand Rounds with our case presentation from Dr. John Kelly, the original president of the American College of Lifestyle Medicine, the founding president. And Dr. Caldwell Esselstyn will be our guest panelist. We get to hear his wisdom. So once again, thank you to everybody. Thank you to Bob Frankie for being our engineer tonight. And we look forward to seeing you soon. Good night, everybody.
Well, really appreciate your input.
Nice job, Kim.
Good night.
Thanks.
Thank you.
Thanks.